We're going to have our lunch talk, which is titled Beyond RAS Blockade, Dual Endothelin and Angiotensin Receptor Antagonism for Superior Proteinuria Control in IgA Nephropathy. And our speaker will be Dr. Jessica Coleman from Medical Associates in Beaufort, South Carolina.
So much. Thank y'all so much. I feel really honored to be here today, and I wanted to thank Trevere and thank GlomCon for having me. I have the dubious distinction of capturing your attention while you're enjoying what looks to be a much more elevated turkey sandwich. So hopefully I'll endeavor along that pathway. But just to give you a little bit of an idea, my name is Dr. Jessica Coleman. I'm a private practice nephrologist in Beaufort, South Carolina, Hilton Head Island, South Carolina, and Savannah, Georgia, so what we affectionately call the Low Country. And I'm really here today to talk a little bit about a subject matter that's really near and dear to all of our hearts, which is really IgA nephropathy and how do we better serve our patient population. So let's talk about really what we do matters. So you'll hear a lot of my sayings throughout the talk today, and if you came to my clinical practice with me, my staff will tell you that I have little kind of carve-outs that I say throughout the day. And so oftentimes I'll tell my patients, what we do matters. What we do first matters for our patients. We have a good degree of GN in our neighborhood, and it's, I think, because we take care of a lot of patients from a large marine training camp called Parris Island. And I think that we get a large amount of young, oftentimes males, who have underlying disease processes that come to the surface when they're put in the pressure cooker that is recruitment into the Marines and boot camp. What we see here is that these patients, I think, are different from many other young males in that they get annual physical exams that is by necessity, not only blood work, but also urinalysis. And so as a result, we have the opportunity to identify the disease state sooner. So let's really talk about how are we going to upgrade our foundation? How are we going to consider what the right steps and what the right pharmaceutical paths are for these patients? And as we go along, I'll try to pepper a little bit of my experience in. Obviously, this is a sponsored talk, and so we do have to disclose that. But I think it's always nice to start one of these talks off with just the indication. So who are we looking to treat with FILSPARI? FILSPARI is indicated to reduce proteinuria in adults with primary IgA nephropathy at risk of rapid disease progression, which is generally a urine protein to creatinine ratio of about 1.5 or greater grams per gram. So this was, of course, approved under an accelerated approval. Many of you who are here in the audience today, I know, were investigators in the trial that we're going to discuss today. And one of the things that I think is very exciting around the corner is, of course, the full approval is coming up on the timeline here in early September. But we don't know if FILSPARI at this time slows kidney function decline in patients with IgA nephropathy under that accelerated approval. And so we really want to make sure that we follow along and see what happens in September. So I tell patients frequently that just because this medication may be right for a lot of patients, it may not be right for you. And there is important safety information that we have to be cognizant of. And so there is a boxed warning surrounding FILSPARI because of the risks of hepatotoxicity and potential birth defects. So FILSPARI is currently available through a REMS program. Under this REMS program, prescribers, patients, and pharmacies must enroll in this process. And one of the things you'll probably hear me say more than one time throughout this talk is I actually embrace the REMS program. I enjoy the REMS program. Myself personally, my experience is that it has allowed my patients, or at least my perception of my patients, better compliance, because as a result of being obligated to get a lab, they're more likely to take a medication. Again, that's just my personal experience, but something that has been kind of an unintended benefit. Obviously, we want to make sure that we are evaluating patients' liver function tests, not only before starting FILSPARI, but then monthly thereafter for the first 12 months, and then every 3 months thereafter while on therapy. The embryo-fetal toxicity, we know that our experience with ERAs, endothelin receptor antagonists, that there is the potential for birth defects, and so this is certainly something you're going to want to caution your patients about. Of course, we want to make sure that we counsel our female patients to have a pregnancy test before they initiate FILSPARI, and we want to make sure that they are using appropriate contraception and that we talk to our patients about that. So obviously, FILSPARI is contraindicated in patients who are pregnant, and of course, we don't want to co-administer FILSPARI with any angiotensin receptor blockers, ARBs, ERAs, or direct renin antagonists like allosterin. And because of this hepatotoxicity, we do want to make sure we're monitoring those liver function tests on the advised schedule. We also want to make sure that we advise patients if they start to develop any symptoms that are suggestive of hepatotoxicity, that they communicate that with us so that we can evaluate their liver function tests, perhaps even off schedule in advance of their next scheduled lab test. And then when we talk about the REMS program with our patients, I think one thing that we really want to make sure that we underscore to the patients is that, at least in my personal experience, I view the REMS program as being here for the patient's safety. Again, prescribers, patients, and pharmacies must all be enrolled in the REMS program, and so we want to make sure that these specialty pharmacies that are enrolled are the ones that are dispensing FILSPARI to our patients. So let's talk a little bit about, first and foremost, mechanistically, why we think FILSPARI is appropriate and really what it endeavors to change in the IgA landscape. So as has been described really nicely already today, and I hear yesterday as well, we know that in IgA nephropathy, these deposits of immune complexes in the mesangium can potentially activate two separate pathways that is thought to lead both to progressive and potentially irreversible kidney damage. So when we're talking about this four-hit, this generally accepted four-hit hypothesis of IgA nephropathy, what we're looking here is to affect a change kind of in a targeted manner against that fourth hit, right? So FILSPARI is very unique in that it is a dual mechanism molecule, and it has activity both at the endothelin A receptor and the AT1 receptor as well. And of course, the goal here is to inhibit irreversible glomerular damage. So as I said, it's a single molecule dual action mechanism, and what we see here is, I think what sets FILSPARI apart is that it's not a steroid, right? This is the first and only non-immunosuppressive medication that is FDA indicated for IgA nephropathy treatment, and it's really uniquely designed to target both the endothelin and the angiotensin pathway. So oftentimes when I will talk to some of our peers and colleagues, I will describe not only, of course, the angiotensin 2 pathway. I don't think that takes a lot of description, right? We're all very familiar in this room with the angiotensin receptor and really the true kind of cytokine-like activity that the angiotensin pathway contributes. But I think one thing that's a little bit of a newer kid on the block for nephrologists is the endothelin receptor antagonism in this pathway. So just to give you a little bit of background, endothelin activity has been thought of as potentially vasoconstrictive. So of course, antagonism is vasodilatation or vasodilatory. And what we see here is that endothelin in itself can contribute both paracrine and autocrine functions in the kidney. And so disrupting that may potentially enhance renal blood flow, glomerular hemodynamics, and so forth. And FILSPARI was really uniquely kind of designed to demonstrate not only high affinity, but also consistency in the binding to this ETA receptor and the AT1 receptor. You can see here on the screen, kind of orienting you to the left side, that it has a very high receptor affinity for both AT1 receptor over AT2 receptor, as well as ETA receptor over ETB receptor, over 500-fold selectivity. And in vitro, the analysis shows that the receptor occupancy is very consistent. In fact, the ETA receptor occupancy is 60 to 90% consistently exceeding ETB receptor occupancy. And again, I think that's really important as we start talking about disrupting the potential for the progression of the disease process. The AT1 occupancy, by the way, is over 95%, consistently exceeding ETA receptor occupancy as well. So again, highly selective, high receptor affinity, and essentially very consistent receptor blockade is seen with this molecule. So FILSPARI works directly on these ETA and AT1 receptors, and essentially what the goal here is to potentially slow or delay further damage to the glomerulus, to the kidney. So let's talk a little bit about the trial that really landed us in the position here today. And again, like I say, I know several folks in the room were involved in the PROTECT trial. So I'm going to go ahead and just congratulate you on really, I think, the elegance of this trial design. It's the largest and only head-to-head trial where we take an active disease treatment option, FILSPARI, and we look against current standard of care. And so what's really kind of unique about that is, for me, being in private practice, this most closely mimics what I'm going to do on a day-to-day basis, right? So I'm going to have a patient who has already been on maximum tolerated standard of care, and if I think they are appropriate, I'm going to look to upgrade that standard of care, upgrade their foundational therapy with FILSPARI. So what the authors of the trial did is they looked at FILSPARI versus RAS inhibition, irbesartan in particular, knowing that irbesartan is really only targeting angiotensin 2, and of course FILSPARI has that unique dual action molecule. So the question begs, based off of this trial data, and for the appropriate patient, should FILSPARI replace RAS inhibition as current standard of care therapy? So again, I'm going to reflect back and remind you that sometimes what you do matters first, right? The first glance, the first impression, this is what matters. This is uniquely important in my patient population because, again, many of these young patients who I identify with IgA nephropathy, I may only have for a snapshot of their time. If they're here as a Marine at the boot camp, I may identify the disease, but they may go on back home or wherever after they're done with boot camp, and I may not have the longevity with them. So what I do first matters for these patients. So just a couple milestones in FILSPARI and in its history. The PROTECT data was, of course, led to an accelerated approval in February 2023, and then the 2-year confirmatory results were published in November, like I say. Fast forward to March of this year when submission of application to the FDA requesting review for full approval, and then, like I say, early September 5th, if my memory serves me correctly, is when we expect to hear back from the FDA. So one of the things that I think was really kind of interesting is that the accelerated approval was based off of a reduction of proteinuria at week 36. And to me, this is really compelling. So if I can tear your attention away from your lunch, here in a couple of slides, I'll show you where that data came from. When we talk about inclusion and exclusion, one of the things I think is really important is to look at who is included in the trial and who is excluded from the trial. So obviously included patients had to be biopsy-proven IgA nephropathy. They had to have proteinuria of greater than or equal to 1 gram per day of proteinuria. Their GFR had to be above or equal to 30. They had to have a fairly well-maintained blood pressure. I think all of us would agree that systolic blood pressure less than 150, diastolic less than 100 is maybe still a little bit generous in the blood pressure department, but again, these were the limitations set. And these patients had to be on a maximum tolerated dose of RAS inhibition that was at least 50% of the maximum labeled dosage for at least 12 weeks prior to screening into the trial. So I think that's really important to note, right? We could have a long discussion about what maximally tolerated RAS inhibition dosing looks like, and boy, would that be a robust discussion. So I'm certainly not interested in initiating that discussion today. But I think what really was inherent to me is that this patient population, the authors were very cognizant of the fact that they wanted to make sure that these patients were experiencing as full of a benefit from what is currently held as standard of care and to be included in the trial. Exclusion criteria, I think, makes a lot of sense, right? Patients who had other glomerulopathies, if they had been on any immunosuppression regimens, including corticosteroids, for greater than or equal to 2 weeks within 3 months of screening. Of course, if these patients had greater than 25% crescents on their biopsy, again, this is a patient that possibly needs cytotoxic therapy, I think we would all agree. If they had CKD in addition to their IgA nephropathy, and then certainly in any sort of history of organ transplantation necessitating other immunosuppressive regimens, they were excluded, and certainly pregnant women as well. So if nothing else, I think this trial was unique in kind of its approach. Basically, it was a double-blinded, randomized trial that brought patients in, again, who had been on maximum tolerated RAS inhibition for about 12 weeks or greater prior to randomization. They were brought in, given 50% of the maximum labeled dosage of either Filspari, 200 milligrams, or irbesartan, 150 milligrams. They experienced 2 weeks of that half dosage, and then they were escalated to the targeted dosage, 400 milligrams of Filspari, and then 300 milligrams of irbesartan. Again, the reduction of proteinuria at 36 weeks was what allowed for that accelerated approval. That was an interim primary efficacy endpoint, and then the confirmatory endpoints, including rate of change of GFR at 52 and 104 weeks was described later. The change in the GFR from baseline was described at 110 weeks. So I think there's some important talking points here. So again, as I alluded to earlier, all patients were required to be on a maximum tolerated dose of their ACE or their ARB, whatever they were on previously, for 12 weeks or greater before being randomized into the trial. And what you can see here is that a good number, over 60% of patients in both arms, Filspari and irbesartan arm, did experience the maximum labeled dosage of their prior therapy before being enrolled in the trial. And I think that's important when we start to isolate out the data and the results. So there was no washout period. Again, as a private practice clinician, this is really reassuring to me because this as closely reflects what I'm going to do in clinical practice as possible, where one day they woke up, they took whatever their prior RAS inhibitor was, and the next day they were randomized into the trial. Of course, they discontinued their prior ACE or ARB once they were randomized into the trial. And then I also thought it was really important that we identified that over 90%, actually over 95% of patients in both arms, Filspari and irbesartan, reached the maximum labeled dosage in each treatment group. Now, there is a carve-out. Investigators were allowed to use rescue immunosuppression treatment per their discretion. At the end of the trial, about 3% of the patients did end up requiring rescue immunosuppression per their investigators' discretion in the Filspari arm, about 8% in the irbesartan arm, and I'll show you some of that data later on. But the usage of SGLT2 inhibitors was prohibitive. I'm sure everybody in the audience has questions about, can we use SGLT2 inhibitors? There is an open label extension of this trial where SGLT2 inhibitors and MRAs are allowed under the investigator's discretion, but I do not have that data for you today. So of the 400, little over 400 randomized patients, the first 281 treated were included in this interim primary efficacy endpoint, which is of course achieved at week 36. And then the total data was assessed at week 110. And again, this is that open label extension that goes up to a total duration of 270 weeks. And we're still in that open label extension. So when we compare the two groups, Filspari versus irbesartan, you can see these are very well balanced across age, race, gender, history of hypertension, blood pressure control, urine protein to creatinine ratio, and eGFR. So it was a really nice randomization, but also well balanced across all treatment, all baseline characteristic subgroups. And so here is the meat and potatoes, right? So if there's nothing else that causes you to look up from your lunch today, I think this slide really kind of says it all, and I think it makes us appreciate and understand why the accelerated approval was made available to Filspari. So what we see here is that Filspari provided an additional 45% reduction in proteinuria following the 12 weeks or more of maximum tolerated RAS inhibition as compared to the irbesartan arm. So what we see here is a substantial improvement, a substantial reduction in the proteinuria under FILSPARI treatment as compared to maximum tolerated irbesartan. That to me was really compelling, and I think it should be compelling to most of us in this room. And you can see here that this urine protein creatinine ratio change was really consistent across all baseline subgroups, whether it be EGFR, whether it be protein to creatinine excretion, whether it be race, gender, age, all pre-specified subgroups favored the FILSPARI arm as compared to irbesartan. And so graphically kind of showing this data, we see here that, again, the accelerated approval was based off of this 36-week data where we saw a superior and a sustained proteinuria reduction in the FILSPARI arm as compared to maximum tolerated and maximum label dosage irbesartan. What was also nice to see is that this was a sustainable effect. So not only did the proteinuria reduce rapidly, but in a sustained manner across over a 2-year, 110-week period. And again, that afforded a 10 times proteinuria reduction when compared with irbesartan. And when we talk about glomerular nephropathy, of course, we always talk about complete and partial remission. And so, again, I don't think it will surprise anyone here in the room that, again, we saw a higher percentage of patients, just under 80%, achieving a partial proteinuria remission as defined as less than 1 gram per day in the FILSPARI treated arm, as compared to just above 50% in the irbesartan arm, and then over 30% of patients in complete proteinuria remission as described as less than 0.3 grams per day, as compared to only 11% in our irbesartan arm. But again, safety is paramount, right? So one of the things that I review frequently with my patients are the potential adverse effects. So we do know with our experience with ERAs, of course, peripheral edema is always one of the chief considerations, and you can see this was a treatment-associated adverse effect that was described more frequently in the FILSPARI arm as compared to the irbesartan arm. One thing that I found was interesting, and I like to call out when I show this slide, is that the aminotransferase elevation, your liver function testing, was also, of course, described in the FILSPARI arm, but actually at a lower frequency than in the irbesartan arm. So again, still something we have to be appreciative of the risks for, still something we are obligated to monitor for, but something that was nice to see that there was no drug-induced liver injury following treatment with FILSPARI and comparatively low incidences of ALT over AST 3 times the upper limit of normal. There was no severe cases of edema that led to treatment discontinuation for patients on FILSPARI, and really comparatively low incidences of any of the treatment adverse events leading to treatment discontinuation. There are a couple of things, though, that you should expect when you initiate your patients on FILSPARI. So we should expect to see, as was so nicely discussed earlier today, a potentially initial small decrease in EGFR that occurs within the first 4 to 6 weeks of starting therapy and then stabilizes. Again, I think we're all very comfortable with that hemodynamic effect that we all believe is primarily from the ARB-like effects of FILSPARI. Again, that's my personal opinion anyways. But one thing that we did see was an incidence of a decrease in hemoglobin that, again, is thought to be related to the hemodilutionary effect. It did not lead to any treatment discontinuations, but we did see a drop in hemoglobin as compared to the irbesartan arm. So again, something you want to monitor for your patient population. And I oftentimes will remind my patients that while we look at this medication as a potential treatment option, that of course there are things we want to monitor: hypotension, orthostasis, dizziness. These are some of the top adverse events that were described, so we do talk about that a lot. Now, certainly, while the maximum dosage and the labeled dosage of 400 milligrams a day is your targeted dosage, I will tell you that that is the lovely thing about clinical discretion, that if you do see a patient have hypotension develop, you can certainly consider, I'm going to speak properly one day, you can certainly consider reducing the dosage of FILSPARI, or of course having a dose interruption and potentially re-challenge depending on what your clinical discretion is. Acute kidney injury, hyperkalemia, fluid retention, again, these are all potential things you should be monitoring your patients for. I think these are all things we're uniquely situated to monitor our patients for, and again, something that we're all very familiar with. So I'm not going to belabor the point here. I think we all know how to manage these situations, but certainly something we want to evaluate our patients for. And then, of course, we don't want to co-administer with other RAS inhibitors or ERAs. There are some other potential drug interactions we want to be appreciative of. These are certainly not patients you want to advocate to get up and drink a glass of grapefruit juice every morning, right? So any strong or moderate CYP3A inhibitors, you want to make sure you want to avoid concomitant use of FILSPARI with these inhibitors, just because, again, you want to make sure that the patients are aware that there could be a potential drug interaction. You can also see an interaction with some of these CYP3A inducers as well, antacids. I oftentimes will tell my patients if they take FILSPARI to at least give a little bit of a distance between any sort of antacids they may be taking. Again, there is a pH-dependent solubility to FILSPARI, so you want to make sure that you kind of allow a little bit of a window there. I'll oftentimes tell patients to take their antacid at lunch, and that usually kind of gives them enough kind of a window. None of our patients, I think, should be on any anti-inflammatories, and so I think that's an easy pull. And then, of course, when we start talking about CYP, 2B6, other substrates, PGP, some of the big take-homes here that you're going to want to be cognizant of is cyclophosphamide, tacrolimus, other calcineurin inhibitors, and digoxin. Those are kind of my three highlights that I kind of take home, that we may at least want to be aware of the potential for a drug interaction. And then, of course, any agents that disrupt serum potassium. Again, we've already talked a little bit about the safety consideration for pregnant females, but of course, I do think it behooves us to at least test our patients and ensure that they're not pregnant before we start and have a discussion about the need for contraception while they're on FILSPARI treatment. Patients should not breastfeed while they're lactating. They should not be on treatment with FILSPARI. And of course, if you have a patient with severe hepatic impairment, think child's class B or C, perhaps even A, again, that's going to be a patient you want to avoid concomitant usage with FILSPARI. So once you've identified a patient who could potentially be appropriate for FILSPARI treatment, and I think we have really a renaissance period right now with IgA nephropathy in particular, where we've got an influx of medications with potential for indication for treatment and more on the horizon. I think it's really nice to understand not only how these drugs work, but also who the right patients are for these medications. And I think that at the end of the day, our clinical discretion allows us to really individualize the treatment for these patients. So FILSPARI is a convenient single once daily dosage, 200 milligrams for the first 2 weeks, 400 milligrams thereafter. That's the targeted approach. I will tell you in my own personal experience, this is the approach we have taken with our patients. However, I've spoken to many of my colleagues who have used their clinical discretion to adjust the dosage based off of what the patient needs. But from the perspective of Travere, from the perspective of the trial data, the targeted dosage is 400 milligrams once a day after that first 2-week 200 milligram dosage. Of course, patients should take this whole, they should swallow it whole, they shouldn't crush it, they shouldn't chew it, they shouldn't get caught up, right? If they skip a dose, they shouldn't try to take 2 in one day. And of course, they should try to maintain the same dosing pattern. And so just a word on REMS support and really talking to your patients about the REMS program. Again, we have found this to be a pretty easy discussion in our patient population. Again, our personal experience, nothing that the company has any data on, but certainly our personal experience is that it has allowed, we believe, in our office, better compliance with our patients because we tell them that they have to get this lab done or they won't have drug shipped to them. It's also been very helpful, no offense to those folks in the audience of the male gender, but it's been very helpful for me to make sure that my patients who are young males who don't want to always be reminded of their own mortality. It's been a really nice benefit to have them have an additional check on, if you will. Our patients tend to, once they start to feel better, once they start to do well, they tend to not want to think about being sick, right? And so again, it's just been our experience that having that additional support, having that pharmacy who calls, having the folks from Travere Total Care who can call, it allows us to really kind of help keep our patients on track. But again, you really want to underscore to your patients that the REMS program can help keep them safe, and that's what it's there for. So prior to starting FILSPARI, you want to make sure you discontinue the use of any other RAS inhibitors. Of course, we want to review and evaluate liver function testing before initiation with FILSPARI, monthly for the first 12 months, and then every 3 months thereafter. And you want to make sure you start treatment with FILSPARI in patients who can become pregnant only after a negative pregnancy test. And again, you just want to make sure you're counseling your patients appropriately. This is the QR code. If any of you in the room are not REMS certified, it takes approximately 20 seconds to become REMS certified, in my opinion, but I'm a fast reader. So, you know, I think it's a very easy process. The company has worked very hard to ease that process along. And again, prescribers, patients, and pharmacies must all be enrolled. And so again, this prescriber enrollment form that they say takes 2 to 5 minutes, to my experience was much faster than that, but it is something that, I'll be honest, I also had a lot of help from my medical assistants as well, at least from a patient perspective in getting them enrolled. So I stand on the shoulders of my staff for sure. Travere Total Care program is absolutely something I would encourage you to avail yourself of and really avail the resources for your patients. It allows for nurse educators, for access support, for financial support potentially for the appropriate patient. And again, it's something that we have found very effective in really helping us to take better care of our patients. And then, of course, for any questions, you can always visit traveretotalcare.com. That's the website which will have all of this information and more should you have any questions. So in summary, and hopefully I've left enough time here for us to have some questions if they've emerged, I would really encourage you to consider upgrading your foundational therapy, really upgrading your standard of care in patients with IgA nephropathy with FILSPARI. So it's the first and only single molecule that directly targets both ET1 and angiotensin II, which are both pathways that are thought to really contribute to disease progression. Again, it's the only non-immunosuppressive therapy out there that's FDA approved for IgA nephropathy treatment. Again, for me and for my patient populations, that's something that's of paramount importance for me. Again, it can elevations. What we saw in the clinical trial was a superior, rapid, and sustained proteinuria reduction in a head-to-head trial, right? So that also uniquely sets it apart. It's the only medication that has been looked at head-to-head against an active comparator. It's available through a FILSPARI REMS program, which we've talked about a lot already. And the most common adverse events, in other words, the things you want to tell your patients to monitor for, and you want to evaluate your patients for, are edema, hypotension, including orthostatic hypotension, dizziness, hyperkalemia, and anemia. And so, again, as we kind of close this out, I want to make sure that we all consider in the audience today, really, what's the right treatment option for our patients? If we're only given one treatment option, I like the saying earlier today of 2 biopsies, the second one is, if you only get to do one, the second one is the one to do. So in your patients who have IgA nephropathy, if we only are allowed 2 options for a primary line of treatment, do we want to replace our patients with a potentially upgraded standard of care, or do we want to make give the patient experience kind of a potentially outdated standard of care? I think it's something to think about. I think it's something that we at least should consider. And again, I think the big take-home points here is it's the first and only treatment that achieves a rapid, superior, and a sustained proteinuria reduction against a maximally labeled RAS inhibitor. And that's it. I'd love to take any questions. Was that comprehensive that y'all don't have questions? That's fantastic. Perfect. Well, I'll be around if y'all have any questions. Otherwise, I'm going to give it back to this gentleman. Thank you so much.
Thanks, everyone.